Anyway, we're back, another episode. I'm here with Matt Shepherd. How are you, Shep?
I'm very good, Alex. Yourself? Well, this is
Yeah,
becoming far too frequent. I think seeing more of you than what I am of my family at the moment.
likewise. But it's good fun. We got heaps of topics, and one topic in particular, which has a lot of people emotionally engaged, is the topic of ramping. Now, a couple of caveats up the front, I guess. None of us is representing any places we work. We've got an interest in fixing this as much as anyone else because it is a big problem and it needs to be talked about to, move towards a solution. We can't sort of stay silent. And I think sort of lastly, I want to add, and I'm sure you've got some caveats too, mate, would be that it's easy to think of this as a, ambulance ED problem because that's where you could see it, but it's a system-wide problem, from the start, from the lack of GPs and primary care, and then through, and then to the other end where there's a lack of sort of options for getting people out of hospital. So, but the top of the iceberg, the tip of the iceberg is right at that ED doorstep, which doesn't mean that they're the people at fault. Good, Shep, all your caveats out of the way, and then we will offload what we think about
Where do I
ramping.
start? I've got about half an hour that could go on for here. Look, mate, at the end
Yeah,
of the day, I think it's been important, as you've identified, that we talk about, or just not even talk about, and it is an opinion of myself and an opinion of yourself. We're not representing any ambulance service, and you're not representing any hospital. And I know that our images are often attached to those facilities that we actually work for. But I think more than anything, I just want to bring it up as a area of discussion. There's no short-term fix for this, mate. I think that's ultimately what it boils down to. There's things that all clinicians can probably do to make a little bit of an impact in the way that it's actually going and ways to move forward. And people, we put a post out yesterday about this, and the response was massive. We got lots of people coming back to us and telling us, you need to do this and you need to do this, and this is how they need to fix it. There's some wonderful ideas, and people are extremely passionate about ways in which they can improve it. But it is a long-term fix. And, I think as you've quite correctly identified, it's not the paramedic hospital interface that's the issue. It's both the other end and the other end as well. So you've got all sides which are having an impact. But unfortunately, that interface between emergency department and the ambulance services is where the issue has been encountered the most. And, let's just talk about some ways in which the people can do some stuff to fix it.
yeah, yeah, good. So, the ED, the ambulance drop-off, that is the bottleneck, isn't it? If you think of a city of 1 million people, on any given day, 1,000 of those are going to get a symptom. Now, whether that's a pain in the back or the chest or whatever, Now, some will go to their GP, others will go to an urgent care, other people call 000 because this feels just like the heart attack they had 18 months ago, so they're worried. People access the healthcare system different ways. Now, that first step, if we just look at the ambulance side of it, I guess the first thing to say is that out of everyone that called 000, not everyone gets an ambulance, and that's an improvement from, I'm sure, decades ago. If you dared to pick up the phone and dial 000, there'd be someone at your house within minutes. Whereas now there's all sorts of way of still or receiving an even higher number of calls, but managing that in different ways.
Yeah, and I think that's really important to identify is that it's been recognised that there are issues with the amount of people calling for ambulances. And so, a lot of ambulance services have changed the way that they receive calls. And so rather than just automatically dispatching an emergency ambulance, some of the calls with their initial presentation and their initial complaints are redirected off to referral services, where a triage practitioner, whether that's a paramedic, nurse, or whoever else, will take a phone call and take some more detailed history taking about what the person's complaints are or their issues are. And often we find with that, the ambulance is actually not required for transport to hospital. And so they can organise things like sending them to a GP or booking a GP appointment or referring them to another service which they can get managed rather than presented to emergency departments or to ambulances in emergency departments. So the other thing that I want to talk about is the other issue, and this is the starting issue, is that people have gone, oh, well, what I'll do is I'll go and see my GP and I'll go and talk about my complaint and my issue that I've got. So they ring up their GP and they go, I'd like to come in and see Joe Bloggs because that's who I normally see. And they go, yep. Next available appointment is in 3 weeks' time. And you go, well, 3 weeks' time is going to be no good for the issue that I'm facing right now. So what else can I do? I know if I go to the hospitals are always really busy in the emergency departments. My local doctor's not available. Well, why not call an ambulance, mate? If I call an ambulance, then I get got a frog in my throat.
Yeah.
A trained medical professional is going to come in a vehicle, turn up to my door, assess me, and tell me what I need to do. That sounds like a great option to me. I don't know about you.
No, I think that's you hit the nail on the head there, because people ultimately at the end of the day want reassurance. Now, if I got a symptom, I could just tell that to the wife and hope that she says, no, you'll be all right, stop complaining. Oh, well, then I've passed on my concern and someone's reassured me. But, the partners or significant others may not feel confident sort of reassuring people. So they say, well, maybe we should get some help. And you've outlined the different ways they could access the healthcare system. And, similarly there, ambulance turns up, you get a set of normal numbers, but the story's a bit off, or there's a couple of risk factors. You're not then sort of necessarily always happy to provide that reassurance that they've called for. But just while you mention it with the GPs, people got a symptom, they ring up, they want to see the GP on that day. So the benefit would be that this GP knows the past history, they know the patient, they can sort of make a more measured, sensible decision. The problem is that sort of GP stuff should be all about sort of primary care. And working in a GP practice now, it's become so much about symptom management that we do very little primary care and, primary preventative care. I mean, like who do you go to do your annual physical and blood pressure and get that down to minimize stroke? And, this should be the work of the GPs. And obviously there's a mix of symptoms, but certainly working in a GP place, I reckon 9 out of 10, and I might see a skewed sample, but 9 out of 10 come in with a symptom. I'm sore here, this doesn't work there, whatever. There's very few that come in and say, no, I feel fine. I just, want to talk about life or blood pressure or preventative strategies or diet. So, yeah, good. Now we're moving towards the hospital here, aren't we? But people can see that the bottleneck is narrowing.
Well,
so people have tried to access. Yeah, go ahead.
I think one good thing you mentioned there is talked about primary care clinics as well. So people need to be aware, and this is not just the ambulance clinicians that I'm talking about here. It's other healthcare providers and also patients themselves. They need to be aware that there's other things available other than ambulances and hospital emergency departments. And we spoke just about doctors' clinics and trying to get in to see your local doctor, and sometimes they're not available. So urgent care centres or primary care clinics, there's a multitude of them that are now available. So one of the issues that the public face is that going to your GP, when I go and see my doctor who I like to go and see, I pay, I think it's $80 or $90. I'm not exactly sure the fee. I get a bit of it back from Medicare, but I'm still paying out of pocket to use that service. Now, if you've got ambulance subscription and you call an ambulance, you get attended to by a medical professional, it costs you nothing. And so, a lot of those bulk care, bulk billing facilities that you used to go to are no longer available. And so people can't afford to pay to go to the doctors like they were able to go to the doctors in the past. So that makes it a lot harder. But certainly there's the options. So GP clinic, urgent care centres, primary care clinics, obviously then people start moving towards ambulance or self-presenting to the emergency department. And so this is where we start to, you talk about that bottleneck. We're now getting to the emergency department situation. There's, from an ambulance perspective, there are options other than transporting patients to hospital. And obviously this depends on patient's clinical condition as to whether that person needs to be transported. There's clearly obvious situations where the ambulance clinicians can say, there is no need for you to present to an emergency department today because of your clinical presentation. This is something that you can go and see your GP for next week or the week after. And that should be it. Leave it at that. Document it, move on. There are cases that you turn up to where you go, I'm not sure, but what I will do is I'll consult with the virtual emergency department, which we have here in Victoria, which is a fantastic service to aid clinicians, but also provide a bit of reassurance and options for patients in the line of scripts, and maybe x-rays and maybe referrals to other services that they can't get by just calling an ambulance service. The important thing to know is that the people of the public can actually do virtual ED by themselves. So if you've got a complaint of some sort, you can ring the virtual ED from home and have a phone consultation with an emergency physician from a hospital who can also give you some direction rather than using an emergency ambulance service. So that's a fantastic service here in Victoria. I don't know whether that's used elsewhere in other states, and certainly I'm not sure whether it's used around the world. I would imagine that it's something that's developed elsewhere as well. Do you know anything further?
Yeah, telehealth solutions. They're far on the rise, they're happening for every condition. And what typically happens, I think what's a bit unique might be that this is the great unwashed emergencies attending that to telehealth. A lot of places would have telehealth for particular conditions. You've been diagnosed with concussion, here you go, or some clinician thinks you're having a stroke, ring up this number, or so you've sort of seen someone beforehand.
If somebody thinks you're having a stroke, I think you should call an ambulance, shouldn't you? That's pretty straightforward.
No, you'd call an ambulance, you get to, but we do telehealth. They're from rural EDs, we do telehealth with the neurologists. But look, that's a good point. The problem I find with all these sort of alternative pathways and the sort of messaging that comes out about sort of emergency services for emergencies only is that people don't know, and we don't know.
Yeah.
And it's not like every chest pain is sinister and every back pain's fine. That occasional back pain will be at AAA and the patient just, I didn't want to bother anyone. And so it's well and good in hindsight to say we only want to attend to or treat sort of emergencies, but we only know that after time, observations, serial stuff, exams, x-rays, CTs, the lot, So now this is
I get that
a challenge.
I work on the other end of the phone sometimes with people calling for ambulances, and sometimes we have ambulance crews questioning the dispatch, which is quite reasonable given some of the information that can be on the data terminal that they're dispatched with. There's certainly sometimes there's limited information just due to how busy the call takers are, that they can only get in so much before they need to move on to the next call. And therefore the dispatch to some of those jobs seems a little bit wrong. But you have to remember, for clinicians and telehealth and all the rest of it is, you don't have that patient in front of you. And sometimes making changes to dispatch or anything like that can actually take a lengthy process to change or redirect that call to the appropriate service. So, that's a little bit of a side note with regards to making a decision from telehealth or clinicians or anything like that. But I think, so I mentioned that ambulance services have got the option to look at alternative pathways. However, sometimes they need to bring the patient to the emergency department. This is, and I definitely don't want to point fingers at anybody, because I've worked as a nurse before at triage, and I know how busy it can get at triage. And, you have a waiting room of patients that you want to look after, and all of a sudden you've got ambulances pouring in as well with patients that need to be cared for too. And at the end of the day, you can only have a limited amount of beds. And once those beds are full, they're full. You can't do anything else. You can't generate space out of nothing. And having ambulance crews come in with more patients who are lower acuity, certainly probably not needing the ambulance care right now, but you don't want to put them in the waiting room either, because your waiting room is already full. and you don't need to take on any further or extra workload because that may be unsafe in itself. So it's a hard situation to be in.
Yeah, for sure. And the reason ED is full and there's no beds is because all those patients have been admitted, but there's no beds further in the hospital.
Yeah.
And that's because, very few sort of get discharged at the end of the day. I mean, it doesn't have to be sick, even if you were young and fit. If you'd come in for an operation, an appendix or a little cut or whatever, you're not sort of got to go home at 8 o'clock at night, you're going to stay, observe, see if anything worsens, get a bit of pain relief and go home next morning. So, yeah, once the evening kicks in, there's very, very few discharges from all sorts of hospitals. And yeah, once the ED is full and there's no beds on the ward, what do? They pile up. Yeah. So, mate, if I may, how about this for an analogy? Just because I know a bit of cardiac anatomy and physiology better than all this sort of politics and stuff. The heart is the sort of ED, right? And then what comes into the heart is the SVC and IVC. The SVC, that's the ambulance bringing in patients. The IVC, that's people walking into ED, right?
Mm-hmm.
And then in ED, they sort of do a loop through the lungs. We get rid of 80% of the people that come to ED. But the other 20 have to come in. But then the poor left ventricle can't get rid of those 20% because the whole hospital's full, systemic overload. So if you think of this as a sort of heart failure situation, you've got increase preload with number of people walking in, number of people coming in by ambulance. You've got a poor, struggling, overworked ED, and then you got huge afterload because there's no rehab beds in community, the hospital's full, this sort of stuff. So the management for this situation is obviously not a quick fix. You can understand if you go to someone with heart failure, it's not a matter of putting in 3 extra cardiac myocytes in that heart. That's not going to fix it. We need reduce preload, reduce afterload, and support the struggling left ventricle. So
CHF, mate. Congestive hospital failure.
Yeah. I love it. That's true. And some of the laws when it comes to heart is the old Frank Starling.
Law,
and I think that's perfect because
100%.
If we don't have enough patients, early morning or whatever, some happens eerie. There's no patients in the waiting room. There's no patients being brought in. The EDs then, there's very little preload. And if I dare say, I think we're pretty inefficient when the pressure's not on.
Mm-hmm.
That's when people get the thoroughness. We'll organise this. Oh yeah, an outpatient test here. We'll sort and we'll check some extra bloods and we'll ring and chase down results. This is all well and good and should happen to most, but yeah, when the pressure increases, you become more efficient. But of course, the Frank Starling curve, mate, as you know it, once you push it too far, it collapses.
It's ineffective.
So yeah.
That's very true.
So we've got the issue, We got to get flow. We got to get patients through and through, just like blood's got to go round and around. And if you go to someone in CHF, whether that's congestive heart or hospital failure, if you go to someone like that, I guess you'd want to assess though, are they in heart failure because of AMI, which would sort of be an issue there at the ED level, where there's been a staff shortage or beds are out of action because of renovations or whatever. Or is it because they're overloaded and been drinking too much water or had too much IV fluids, or is it because the blood pressure's shot up? So just like you would decide with a patient who's in failure, like where's the problem? Would it be true? You don't always sort of find a clear course though. They're just they're overloaded, and it's a bit of struggling hearts, a bit too much fluid, and the blood pressure's been up, and you're not going to fix that with one button.
No, you're not. And as you know, there's obviously multiple things that can go into that. And I like the analogy. I think it fits very well, the congestive hospital failure. And I don't want to say hospital failure because it is a system failure as well. It's not just hospitals. There's multiple things going into it.
Congestive health failure. Health system failure.
Yeah, there we go. Yeah, congestive health failure. Well, there's your title for your talk today, congestive health failure. Now, so the other thing I want to talk about, because we're moving through this tunnel now. We've come into it's gone down into this bottleneck thing here. From a pre-hospital clinician thing, what can we do? Well, you can present to the charge nurse and explain your story clearly to them and give a clear indication. This patient that I have here is quite stable. They have been stable for a long period of time. I've provided them with some analgesia. However, their vital signs indicate that over the last 30 minutes, hour, they've remained stable. They seem a suitable person to go to the triage. So a suggestion, I don't want you to tell triage staff what to do, but certainly you can suggest that on your professional opinion, this person is suitable to be placed into a triage area, the waiting room for evaluation and waiting until they're actually seen. The other thing that you can do is, if you've got 10 paramedics standing around with patients who are all lower acuity, then maybe one of the paramedics can look after 2 patients and 1 ambulance crew can clear. And they've called it cohorting within the ambulance service that I work for now. And maybe that's something else that I don't know if it already is, but could be adopted in other ambulance services elsewhere as well. So the next thing that we need to talk about is, you've mentioned gone through the left ventricle, and we're into the system now. The system is the wards and also the aged care facilities. So the aged care facilities are a bit of an issue on both sides, because the aged care facilities don't have beds for people from the hospitals to go to, but they're also one of the main groups of people that call for ambulances all the time to take people to hospital. So it's a massive problem, and to fix it will take a very long time and lots of really smart people, much smarter than you and I, to come up with the ideas and put the policies and procedures in place to actually make a difference.
Yeah. But if we think of these sort of, there's that sort of pre-hospital ED phase, and then there's the ED ward intersect, and then the ward nursing home or home. It would be fair, it would be difficult to implement, but it would be fair, let's say, if there were 10 patients ramped, instead of having 10 ambulance patients ramped, we'd do 3 at each of those stations. So say instead of having 9 patients ramped with IV, there should be then only 3 ramped with IV, 3 go up and sit on the ward, sit outside, lay in the corridors, and wait, have a ramping clinician there, and then 3 back at the nursing home with a nursing home cohorting sort of ramped person.
I think that's a great idea, Alex. I think, the idea and concept works really well until you go staff. And, you look at a lot of the issues why aged care facilities sometimes call ambulances, that we do not have the staff to care for these patients here at the moment. And our hospital policy or our facilities policy indicates that if they've had this sort of injury or this type of fall, they go to hospital for assessment. The other end of it is, if you put patients up onto the ward, staffing is once again an issue, because we have shortages. We have shortages in the pre-hospital environments in aged care facilities, shortages in emergency department, and shortage of staff on wards as well. So I think the idea of being able to put people up there is great, but it's probably unsafe. That would be my only concern.
Well, it'd be unsafe, but so is having 10 people at the doorstep in ED. So we just got to weigh up. I mean, at least they have had assessment, management, the ball's rolling, but they could deteriorate just like anyone else. But the nursing home, they have a policy to call or what have you. Like, shouldn't these nursing homes be sort of somehow owned or operated by the hospitals? And then they could take a bit of a charge. And if I'm in charge of an ED and there was a nursing home down the line and something happened, they're falling out of bed, they must have a CT brain or whatever. it'd be far quicker to send one of the registrars in an Uber and go down and have a look at this person and make a plan and just come back in the Uber. And we've done research on this and shown that increases the stuff you want to increase, satisfaction, minimize transport times and this sort of stuff, and it's safe to do. So there's research in this space, there's ideas coming out, but I think the step one must be that we should be able to talk about this, openly, honestly, and come up
100%.
with some.
Because we were actively involved in doing some research on this and performed some surveys and so forth.
Yeah.
And there's some good information that came out of that, although not yet published, so we can't really talk about it too much. There's a lot of opinions and a lot of thoughts about how we can correct this stuff. And I think if we get everybody's ideas together, surely there's somebody in there, maybe there's somebody that's listening to this podcast that's got a fantastic idea but doesn't have the platform to get that information out. So, if you've got any great ideas, feel free to send them through to us and we can look at ways in which we can share that information and hopefully send it to the right people.
That's it. Present your idea and we'll poke holes at it. And after half an hour of interrogation, when the idea is watertight, we'll take it further. So, one more thing, fascinating needs to be fixed. One more thing. What about the patient? Is that what you're going to say?
No, I was going to say about culture. So the other thing that we need to talk about is probably the culture from pre-hospital clinicians when they arrive at the hospital. Personal anecdotal experience from what I've seen are some clinicians are more than happy to help out in any way, look after patients, look after other people's patients, do what they can to obviously deliver the best care for the patient that they can, and also help other ambulance crews get out back into the community. On the other hand, there are clinicians that I've seen and witnessed firsthand in which they can do things to ensure their transport of the patient works in their best interest, and that is to ensure that they get to finish on time, which we are all entitled to do. I'm not dismissing that at all. We're all entitled to finish on time, but work the system so it works in their best favour. So as an ambulance or pre-hospital clinicians, we need to ensure that we're delivering the best care for our patients, but also looking after our colleagues and so forth as well. So we need to work together collectively as a team so that we're all doing the right things for the patients and each other.
Yeah, spot on. And the last sort of stakeholder group in all of this is, of course, the patient. Fancy having a fall, you're old, you're on blood thinners, and then 4 hours on your back on the ambulance stretcher, just waiting for a bed. And I'm glad they're in the care of paramedics who swing in periodically, they buy the stretcher or checking in on them. Do you need any pain relief? How you go? And this sort of stuff, because that's one-to-one sort of level care that they're getting whilst they're waiting in a hold up. So you wouldn't want to be a rammed patient at the end of a long line like that, just waiting. But whilst you're there, you're with some great clinicians who can tell some stories and you can come up with some solutions to ramping.
Absolutely. And I think, if ever you're up Alex's hospital, make sure you get into him and ask him plenty of questions to see if he's got any ideas of how he can fix the ramping issues. But I think what you're speaking about there, Alex, is really important. We are, at the end of the day, we are clinicians who are there to help people.
Yeah.
And we need to ensure that we maintain that good quality care, whether you are bouncing along the freeway, whether you are on the side of a hill tending to a patient, or whether you are in the emergency department with the same patient but have been there for multiple hours. I know it's not the glamorous job that we signed up for in the pre-hospital space. However, this is the space we are in at the moment. We still need to look after our patients and we still need to treat them with dignity and respect and give them the care that they actually deserve. So continue on with that. You won't have any issues.
Nah. Good.
Good.
To be continued. See you soon.
Bye, mate.
Cheers. Bye.